All right. Hello, everyone, and welcome to today's Cardiogenic Shock Registry virtual grand rounds. My name is Shayna Costello, and I am the Senior Program Manager for the registry. And I'm so thrilled to have all of you with us today. Thank you for spending part of your afternoon or your morning here with us today. We've got a great call, and we're just thrilled to get started. And you can go to the next slide, Marielle. So just a couple of quick housekeeping items before we begin. Please note this meeting is being recorded and the recording will be archived on the Cardiogenic Shock Registry's website. And we just ask that everyone please stay on mute unless you come off to ask a question. Questions should be held into our designated Q&A times. We'll have one for both of our speakers today. And just a quick note that we do have a really tight agenda today. So we actually would recommend that if you have a question, go ahead and put it in the chat. And that way we can kind of keep those as we move towards those Q&A sections. All right, and then next slide, please.
Great, thank you.
Right. And go ahead, Dr. Morrow.
Yeah, no, wonderful. I'm Dave Morrow from Brigham Women's Hospital, and along with Mitch Krukoff, who you also see on the line, I am one of the co-chairs of the AHA Cardiogenic Shock Registry, and we're very grateful for your joining the second in our series of grand round webinars on the topic of cardiogenic shock. And as you'll see, over the coming year, we'll continue to develop and dive more deeply in a staged way into this complicated field and trying to work through together ways that we can provide better care and improve the outcomes of these patients. If you go to the next slide for me, here's our agenda for today for the next hour. I'll introduce our speaker in just a second, but first we'll hear about how to recognize cardiogenic shock early and assess the stage and severity of cardiogenic shock. We're really starting at that building block at the very beginning when you encounter the patient with possible cardiogenic shock. How do you recognize them and assess them? And then we'll have a interesting case study that ties directly into that before we end with both a quick overview of the AHA Cardiogenic Shock Registry from Professor Krukoff, and then a demonstration of all of the features for those of you that are participating sites where you can access your own data for your own institution and evaluate relative to the benchmark of what's happening around the country in the AHA registry. So if you go to the next slide. And so it really is my true pleasure. We are very grateful to have Dr. Shashank Sinha join us today as our featured speaker. He has many titles to his name, but maybe most relevant for today, he's the medical director of the cardiac ICU and also the director of cardiovascular critical care research at INOVA. And we're very grateful for your joining today, Shashank. I'll hand over to you.
Well, thanks very much for that very kind and cordial introduction, Dr. Morrow, and really appreciate the opportunity and privilege to spend this hour with all of you on how to recognize cardiogenic shock early and assess the stage. Next slide, please. So our objectives over the next 20 minutes or so are to understand the challenges in improving outcomes in cardiogenic shock, and then recognize the standardized nomenclature for diagnosing the severity and etiology of cardiogenic shock, and finally implement the SCAI and SHARC classification schema for cardiogenic shock, which will segue into the case presentation that follows. Next slide, please. So cardiogenic shock is a multifactorial hemodynamically complex syndrome that unfortunately has had persistently high morbidity and mortality over the last several decades. And the pathophysiology is equally as complex, traditionally defined as an acute ischemic insult due to acute myocardial infarction, resulting in progressive cycles of ischemia and inflammation, culminating in progressive cardiac and multi-organ dysfunction, and ultimately death. Next slide, please. Cardiogenic shock is a common cause of admission and mortality in tertiary and quaternary CICUs, as shown by this data from the Critical Care Cardiology Trials Network. Next slide. But importantly, not all shock is created equal. Increasingly, as you can see on the right-hand side here, AMI cardiogenic shock, as shown on the initial presentation, is now less than a third of the cardiogenic shock that is encountered in tertiary and quaternary CICUs, as seen in this analysis, again, from the Critical Care Cardiology Trials Network. And non-ischemic etiologies, or ischemic without AMI, now comprise nearly half or more in terms of their prevalence. Admittedly, among all shock patients, cardiogenic shock still remains the dominant form of shock seen in tertiary CICUs. Next slide, please. But how should we define and classify cardiogenic shock? And there have been varied definitions from a number of clinical trials. And if we go to the seminal shock trial by Judy Hochman and colleagues that was published in New England Journal in 1999, we see that the initial definition was of hypotension, as defined by a systolic blood pressure less than 90 millimeters of mercury for at least 30 minutes, or the need for supportive measures to maintain a systolic blood pressure greater than or equal to 90 millimeters of mercury, with signs of hypoperfusion, namely cool extremities, oliguria, or tachycardia. However, that definition has not been consistent across clinical trials. Next slide, please. And so it was not until the Society for Cardiovascular Angiography or Intervention, or SCAI, developed a new classification showing cardiogenic shock as a continuum, as we go to the next slide here, that shows it really as a continuum from SCAI A, those at risk, to SCAI E, those in extremis. And we'll spend some time here to make sure that we truly understand how each of these categories is defined. SCAI A defines those patients who are at risk of cardiogenic shock. They're hemodynamically stable. They may have a large anterior myocardial infarction. They may have decompensated heart failure, but they do not have any signs of either hypotension or hyperperfusion. SCAI B defines those patients with hemodynamic instability, which includes hypotension, tachycardia, or abnormal hemodynamics, but without end organ malperfusion. SCAI C is the classic cardiogenic shock patient that has evidence of both hypotension and hyperperfusion, and usually requires some degree of either pharmacologic or mechanical circulatory support. And SCAI D is a patient that is now deteriorating and has failed to respond to the initial therapies for this patient. SCAI E are those patients who are in refractory shock or actually have impending circulatory collapse. And it's important to recognize that cardiac arrest is actually a modifier in this classification, as we'll see shortly. Next slide, please. In the 2022 revision to the SCAI classification, the authors noted that SCAI shock severity is actually only one axis that really needs to be defined in triangulating our understanding of these patients. It also includes phenotype and etiology, including whether it's acute or acute on chronic, the ventricular involvement, whether it's right ventricular, left ventricular, or biventricular systolic dysfunction, whether the cardiopulmonary failure or multiple organ involvement is implicated, as well as biochemical phenotype, including hemometabolic shock. And then, of course, there are an array of risk modifiers, including cardiac arrest, as was previously noted, a systemic inflammatory response, as we see a septic-like inflammatory cascade in many of these patients, and then, of course, frailty and risk of other complications. Next slide, please. Importantly, the 2022 revision to the SCAI classification showed that it's actually dynamic, and that normalization of perfusion metrics while on support actually improves the patient to SCAI C, and subsequent removal of support then can allow improvement to SCAI B or A. Conversely, an acute catastrophic event actually places the patient in SCAI E for extremis or refractory shock. All other patients actually must stop at least transiently in SCAI C for an initial intervention. Next slide, please. The SCAI shock was validated retrospectively by Jake Jenser and colleagues at the Mayo Clinic in their single center analysis. And you can see the stepwise escalation and association with increased both in-hospital and CICU mortality. Also by Benedict Schraga and colleagues in their European registry, and then prospectively by David Barron and colleagues at Centera. Next slide, please. So how should we approach identification of cardiogenic shock? And this is the proposal. It's actually a quality improvement tool that the Society for Cardiovascular Angiography and Intervention has developed. And I think it's instructive for clinicians across specialties to use in evaluating their patients. First is, of course, assess their vital signs. Is the systolic less than 90? Is the MAP less than 60? Is the heart rate greater than 100? But then to gather appropriate laboratory data, including a comprehensive metabolic panel, looking for elevated transaminases, evidence of renal dysfunction, or oliguria. Importantly, checking a serum lactate is very helpful. Greater than 2 millimoles per liter is certainly concerning, as well as placement of a pulmonary artery catheter, which if evidence of reduced cardiac index can certainly suggest cardiogenic shock. And then finally, assessing early and often for deterioration, whether that's rising lactate, rising pressure requirements, rising temporary mechanical support, or certainly those patients who are really at extremis with ongoing or recurrent CPR. Next slide, please. So the steps for actually sky shock staging actually occur then in reverse, using the top of the pyramid to evaluate first for extremis. Is the serum pH less than 7.2? Or is there a markedly elevated lactate? Does the patient require a recurrent CPR or ongoing vasopressor boluses? Those place the patient at extreme extremis with associated in-hospital mortality, at least in this analysis, ranging from 55 to 77%, the sickest of the sick. Step 2 is to evaluate for any deterioration. Is the lactate rising? Are there escalating pressure requirements? Are you requiring more than one temporary support device? Are there worsening liver function, renal function, or urine output? Those are sky stage D patients who are deteriorating and are associated with anywhere from 32 to 54% mortality, depending on the presence or absence of cardiac arrest. Does the patient then have any hypoperfusion? And that's a patient that has an elevated lactate, or if hemodynamics are placed, evidence of reduced cardiac indices or cardiac power output, which we'll discuss in more detail perhaps in some of the cases, or elevated transaminases or creatinine or oliguria. Those are those classic cardiogenic shock sky stage C patients that can range anywhere from 8 to 40% in terms of in-hospital mortality. And then finally, does the patient have any evidence of hypotension? Those are the patients that are Sky B that, as you can see, especially with in-hospital cardiac arrest, can be associated with up to 26% mortality. Next slide, please. The Cardiogenic Shock Working Group is a multi-center North American registry that actually now is more global, that provided granular cutoffs for hypotension, hypoperfusion, and incorporated treatment intensity to help make this SCAI classification more granular for our patients. Next slide, please. There's some key findings from this analysis that were published in JACC in 2022. First, as you can see in this complicated table, for any given level of pharmacologic and device-based support, noted by shades of blue, you can see that simply adding pressors for a given level of temporary mechanical support device was associated with a stepwise increase in mortality. Furthermore, as you can see on the graphs at the bottom, regardless of etiology, acute MI shown in the middle, heart failure shock shown in the right, there was a stepwise associated increase in mortality as we increase the number of drugs and devices. Next slide, please. Importantly, and this is one of the take-home messages, patients who present in cardiogenic shock SCAI stage B and SCAI stage C escalate to a higher SCAI stage in 90% or 70% of cases, respectively, during the course of their index hospitalization. And when they escalate, their outcomes are usually worse. This is represented on the graph E on the right, showing if we look at the SCAI stage C patient who may have a 20% mortality on admission, if they remain at SCAI stage C, that's associated at least with a 6% mortality, but those who deteriorate to SCAI stage E are associated with a 71% mortality. I invite you to compare that to a patient who presents de novo in SCAI stage C, which is associated with a 53% mortality. So obviously we need to monitor and watch for deterioration of patients in cardiogenic shock while they're under our care. Next slide, please. So is shock a problem of congestion or hyperperfusion or both? This is a 2x2 axis that was proposed by Sean Van Diepen, Jason Katz, and colleagues in a seminal AHA scientific statement in 2017. And I think it's helpful in defining, again, those patients who are cold and wet in classic cardiogenic shock, or may present in mixed vasodilatory cardiogenic shock with warm and wet profiles, or those who may actually have a deleterious profile of being both cold and dry, shown as to the top right, and euvolemic shock. And then for those patients who may actually have a vasodilatory or distributive etiology altogether, shown on the bottom right. Next slide, please. The cardiogenic shock working group showed that congestion is very common in these patients, particularly right-sided as well as biventricular involvement, and it's associated with increased mortality across sky stages, as you can see on the bottom. Next slide, please. Particularly with respect to heart failure cardiogenic shock patients, I draw your attention to the middle, where elevated right-sided filling pressures and elevated pulmonary capillary filling pressures were associated either for the need for cardiac replacement therapies, shown in orange, or death in these patients. Next slide, please. It's important to have a high index of suspicion for these patients, whether they're found in the ER or in the general wards. They may or may not be on cardiac telemetry. And so these patients can be in the general cardiac telemetry, intermediate care or step-down units, heart failure ICUs, if present at your institution, or in the cardiac ICU, across that continuum of risk that was illustrated earlier. Next slide. The Critical Care Cardiology Trials Network has illustrated that not only is not all shock equal, but there are actually different phenotypes of heart failure-related cardiogenic shock between de novo, such as acute myocarditis, versus acute on chronic presentations of these patients. And as if we go to the animation, we actually see one more, that those patients who especially have cardiac arrest, you can see in the blue, those are the de novo heart failure shock patients that almost mirror the AMI patients shown in gray on the right with respect to their mortality. Next slide, please. This was also shown by the Cardiogenic Shock Working Group, and importantly, de novo shock represents either 1/5 or 1/4 of all heart failure shock patients seen, at least in contemporary registries. Next slide. So I submit to you, and this is another key takeaway slide, that our traditional paradigm seen at the top, where an acute ischemic insult and AMI shock leads to hypotension followed by hypoperfusion with congestion as a later finding, is actually completely reversed in the acute on chronic heart failure shock patient who may present with congestion with hypoperfusion and then hypotension as a much later finding. Next slide, please. The Shock Academic Research Consortium recently published consensus definitions for cardiogenic shock that I think are very instructive and valuable. As you can see, they delineate into an AMI versus heart failure shock, but also include post-cardiotomy shock and secondary cardiogenic shock, which includes arrhythmogenic, valvular, and pericardial etiologies. And as discussed earlier, heart failure shock is stratified into both acute on chronic as well as de novo etiologies. Next slide, please. So again, sky shock provides us the severity of illness. The SHARC definitions provide us important classification by etiology, either AMI, again, delving into STEMI versus non-STEMI, heart failure shock, de novo versus acute on chronic, the secondary causes, secondary cardiogenic shock, in which the causes should be elucidated, and then post-cardiotomy, which obviously occurs in the setting of cardiac surgery. Additional modifiers are present here on the right, which include ventricular involvement, post-cardiac arrest, as well as specific etiologies, including mixed shock. Next slide. So then the holy grail here is, how do we match the right patient to the right therapy at the right place and at the right time? Well, this is a very difficult question to answer, but we've proposed this in a recent published review. If we go to the next slide. And I think it's helpful, particularly with cardiogenic shock teams, to try to elucidate all this information as we try to make time-sensitive assessments about the appropriate therapies for these patients, including the cardiogenic shock features that we just discussed, including sky staging and congestive profiles and etiology, but also patient selection with respect to electrical or hemodynamic instability, their complex coronary anatomy, whether they are candidates for advanced therapies, and then mechanical circulatory support based on your institutional and operator expertise, best practices for vascular access, and relative or absolute contraindications to device. And finally, systems of care with respect to your multidisciplinary, interdisciplinary shock teams and regionalized shock networks. Next slide, please. The SCI Quality Improvement Tool provides, I think, an important framework here for bidirectional interdisciplinary shock communications on these shock calls, in which you should elucidate, of course, the history and physical, the hemodynamic support that the patient currently has, laboratory markers, social history, and code status. This is particularly helpful when taking the initial intake call and triaging and assessing these patients, and then asking, if completed, echocardiographic data, right heart cath data, coronary angiography data, mechanical circulatory support, certainly if the patient is being transferred on that support, and then any overt contraindications to advanced therapies that have already been identified. Next slide. It's important to recognize that in monitoring these patients, serial assessment is absolutely essential. And both clinical, biochemical, and then hemodynamic variables need to be monitored in serially assessing these patients, particularly within the first 24 hours of management. So if we go to the next slide, we see that actually there's a roadmap that has been proposed and forthcoming guidance coming from another professional society, looking at what our initial approach to these patients should be in the golden hour or 2 hours of critical care. This includes, of course, examining the patient, getting a 12-lead EKG, doing a bedside ultrasound, a formal echo if available, sending biomarker testing, including troponins, arterial or venous lactate, natriuretic peptides, and then elucidating the etiology, whether it's AMI or non-AMI related, and then risk stratifying the patient. I would submit that it would be at this moment that activating the shock team might be helpful, but resuscitating the patient, including using vasoactive agents, hopefully not fluid resuscitation in the setting of patients who are congested, but as noted, there are some patients who present in that top right quadrant of euvolemic shock and may require that, as well as oxygenation support as appropriate. The patient is subsequently transferred to either the cath lab or cardiac intensive care unit for further evaluation and management. But if we go to the next slide, we see that it's really the first 24 hours that are often critical in serially assessing these patients, examining, again, those biomarker data, hemodynamics if available, and performing treatment intensity, escalating temporary mechanical support in trying to optimize outcomes for these patients. So if we go to the next slide. 24-hour hemodynamics have been shown to be prognostic, at least in our single center analysis, as present in the IHVI risk score. You can see here both cardiac power output and the pulmonary artery pulsatility index have been shown to be prognostic, at least in this analysis. And then if we go to the next slide, the ALT shock, which looks, it's an Italian registry looking at heart failure shock patients. It's not actually your SCI stage at admission, but your SCI stage at 24 hours seen on the right, where you can see the stepwise association with increased mortality in these patients, suggesting that that first 24 hours is very critical in the management of these patients. If we go to the next slide, we have increasing data coming from the Cardiogenic Shock Working Group that also shows that this first 24 hours can dictate outcomes. And that, as you see here in this Sankey diagram, note that patients in SCI stage B and SCI stage C can have similar degrees of deterioration going down to SCI stage D below. But after 24 hours, that often may be associated with your destiny for some of these patients. To this end, the Cardiogenic Shock Working Group has developed a calculator that's free and available on Apple and Android, and can help you calculate the shock stage, hemodynamics, congestion to monitor these patients. Next slide, please. So as we close here, I think the key things to recognize in classifying cardiogenic shock patients is to really elucidate what is the SCI shock severity and what is the etiology on that initial call in evaluating these patients. and then stratifying them appropriately by either heart failure shock or AMI shock for subsequent evaluation and management. Next slide. We now have machine learning approaches that are elucidating clusters or phenotypes with these patients. And as you can see here, there's a stepwise increase in mortality as we move from non-congested to cardiorenal to cardiometabolic or hemometabolic patients. And this data, again, from the Cardiogenic Shock Working Group was independently validated in the Danish registry. Next slide. And finally, we hope moving forward that we can leverage our electronic health record to develop a clinical decision support platform as we take care and manage these patients. Currently, this Cardiogenic Shock Working Group calculator provides a predicted in-hospital mortality and looking at sort of what the risk of escalation may be for these patients. So as we close here, next slide. My take-home points for you are that cardiogenic shock is a hemodynamically complex and multifactorial syndrome with high morbidity and mortality. A standardized taxonomy, namely SCAI, may facilitate earlier recognition and diagnosis of cardiogenic shock. Novel care pathways are obviously in development, are forthcoming in managing this very critically ill population. I appreciate your time and attention, and I welcome your questions and comments. With that, I'd like to thank my INOVA Cardiogenic Shock team and Dr. O'Connor, my boss. Next slide. Naveen Kapoor and Dan Burkhoff, who lead the Cardiogenic Shock Working Group. Next slide. And of course, Doctors Morrow, Bahula, Katz, and Van Diepen, who lead the Critical Care Cardiology Trials Network. And thanks very much to all of you.
Shashank, thank you very much. Really superior and sophisticated overview of an incredibly complicated topic. I think we have time for just a few questions, so I'll keep my eye open in the chat. But maybe I'll start really leveraging or focusing on the topic for today. How do you help your trainees in guiding them toward that very early recognition of shock? I think that is where we see the most struggle sometimes, is that we see a patient who ends up, even in our own institution, coming to the unit 36 hours after their shock onset. And how do we do better there?
Yeah, it's a great question and a perennial challenge. I think the key is really recognizing that those SCAI-B patients are vulnerable. And in fact, if we have seen any discrepancies between SCAI staging by, the Society for Cardiovascular Angiography and Intervention and the Cardiogenic Shock Working Group definition, it's really to recognize that SCAI-B is bad and that those patients can escalate to a higher SCAI stage if not recognized early. So I think having a high index of suspicion, particularly in patients who aren't responding to your initial therapies, and that's usually within a couple of hours, not a couple of days, to really prevent delayed recognition. Checking serial lactates in these patients, looking at their liver function, looking at what their renal function is doing, not just in terms of creatinine, which can sometimes be delayed in elevation, but their urine output themselves. And then thinking about placement of a pulmonary arterial catheter to help guide recognition and management early, I think has been helpful.
Yeah, and I'd say, building on that, just recognizing often tachycardia in the heart failure patient, where it's really the reduced stroke volume and the compensatory tachycardia before the blood pressure goes down. That is another key that I always try and impart for our trainees. Dr. Kukoff.
Yeah, so thanks, Shashank. Awesome presentation. Just echo David's thanks to you for joining us today and giving that great talk. I want to extend this, though, to push a little more on the role of the PA catheter, because a lot of the growing approaches that you showed are transition-based. I think you said repeatedly that frequent reassessment is key. And yet the role of the PA catheter, I find, around different centers and even across different attendings within one center, is still kind of sometimes present, sometimes missing. So, and I know that sometimes you can go in a cath lab, or sometimes it can go in a unit. But where are we are there certain patients you think really benefit more from a PA catheter as opposed to all Class C and above patients? And if not all, what do you think is the lesion that makes these guidelines as they emerge still not specific, being very specific about PA catheters, other than to say it may be a good thing in some patients?
Yeah, great question. A lot to cover and unpack there. Just briefly to kind of provide an overview, historically, PA catheter replacement for at least cardiogenic shock evaluation and management, at least in the 2013 ACC AHA heart failure guidelines, received a 1C recommendation. That was downgraded to actually a 2B in the 2022 update. That was provided, and it was mainly because the absence of randomized trials to inform that recommendation. I do recognize that many of this audience will be familiar with the ESCAPE trial, which was not in cardiogenic shock, but on severely ill heart failure patients, and did not show a benefit of PA catheter use in the routine heart failure patient looking at 180 days outside alive from the hospital. But subsequent registry-based data, both from the Cardiogenic Shock Working Group, as well as from the Critical Care Cardiology Trials Network, and some other claims-based data from the nationwide inpatient sample and nationwide readmissions database, have been very compelling in showing an association with mortality. And so I think this has become the cornerstone of many shock teams that have developed around the country for advocating for a PA catheter to elucidate the severity. Obviously, if the index is markedly reduced or the patient is congested, particularly that RV shock or biventricular shock, which is associated with more deleterious mortality, I think in those patients it especially is valuable. And so, but to your point, I think among cardiogenic shock centers in our community, it's still less than half, and generally about a third of patients that are actually receiving a PA catheter, as compared to some of our tertiary and quaternary centers.
Shashank, I'm going to take the moderator's privilege and extend this section by just another 2 minutes to give you a chance to answer a question that's come up from multiple people in the chat. And that is, how do you tease out cardiogenic shock from other types of shock? And maybe if you could comment specifically in the absence of a PA catheter. Just how do you do that clinically? And if you were setting up triggers in your EMR, are there any specific things that you would use? And we'll take this as our last question. For other excellent questions in the chat, we'll see if we can integrate those into the case that follows. So go ahead.
Absolutely. A great question. And admittedly, at least for our institution, our criteria for activating the shock team are actually clinically based. Hemodynamics are not actually required, although, of course, often helpful. The clinical criteria are really looking for hypotension, which, of course, is seen in a variety of different shock states, but then looking for a primary myocardial cause of that. I think the SHARC definition provides a nice kind of update there. Either AMI, in which case the STEMI pathway is very helpful, or non-AMI or heart failure shock, which is becoming increasingly more common in these patients. So looking for a reduced EF in these patients seen on echocardiogram, but also markers of congestion. For those that have the sophisticated metrics to calculate, either using velocity time integrals or other variables, calculating cardiac output from their echocardiographic data, that's very helpful, but certainly not required. But there has to be some evidence of sort of hypoperfusion and recognition that the primary insult here is cardiogenic in etiology. I think the challenge particularly occurs in the mixed states, which can occur concurrently, and that's where both hemodynamics and additional data can often be helpful.
And I'd say too, don't underestimate the value of a central venous line and a central venous SAT if you don't have a PA catheter already.
Yeah.
All right, I want to thank you again. Tremendous talk, Shashank. Really appreciate your covering a huge amount of territory. Let's go ahead and move on. And I want to welcome Kurt Ginder, who's from Brigham Women's Hospital. He is a critical care cardiology fellow who is also training in informatics and has a great case for us. Kurt.
Great. Thank you very much for the introduction, Dr. Morrow. I have no relevant disclosures to the case, and please interrupt me if at any point anyone has questions or thoughts. Hopefully this can be interactive and following on an excellent overview of sky shock staging. Next slide, please. So I'd like to start. This is a 37-year-old. She has a history of hypertension, not on any medications, undergoing lifestyle modification, and obesity, who's now presenting with nausea, emesis, and shortness of breath. Thank you. 2 months ago, her case starts with a viral prodrome. This was characterized by progressive nausea, emesis, early satiety, and there was a presumed GI source. And so she underwent a extensive GI evaluation, including abdominal ultrasound, an EGD, and an abdominal CT, which were all unrevealing and unremarkable. She's now presenting 2 days prior to her current presentation with worsening of her symptoms, progressive nausea, and now new fatigue. Her blood pressure in urgent care is noted to be 92/60 millimeters of mercury. Her heart rate is 91 beats per minute. Her white cell count is 10, and a creatinine of 0.9, and we don't have a relevant baseline to compare that to. Similarly, her liver, her AST and ALT are slightly elevated to 109 and 123. Again, she hasn't been taking much in. This was presumed to be a GI illness, and so she was given a liter of IV fluid and discharged home with close PCP follow-up. She's now presenting to the emergency department directly from her primary care follow-up that had been scheduled with progressive weakness, now feeling poorly, really unable to walk any meaningful distance, along with new orthopnea, which is the first she'd experienced that, as well as worsening of her shortness of breath. Next slide, please. In the emergency department, here's her initial evaluation. She's afebrile. Her blood pressure is 113/86 millimeters of mercury. Her heart rate is newly tachycardic at 122 beats per minute, and she's saturating well in room air. On exam, she's anxious, she's unwell appearing, she's uncomfortable, really kind of moving around in bed. Her cardiac exam discloses tachycardia, frequent PVCs on the monitor, along with an S3 gallop, no appreciable murmur, and her neck veins are quite distended. And she's found to be cold on exam, both distally and proximally over her thighs.
Kurt, maybe I'll actually just have you pause there and get Dr. Sinha's reaction about just the clinical presentation here and any flags that he sees.
Yeah, no, excellent case. And obviously, if we could go back actually one slide real quick, just want to highlight the point that, these patients obviously don't read the textbook. And so having that high index of suspicion, I think, is very important. If we recognize a patient sort of presenting with nausea, fatigue, yes, it doesn't mean the technical clinical trial definition of hypotension, but 92/60 is certainly worrisome. A heart rate of 91, as Dr. Morrow illustrated earlier, is worrisome. And obviously elevated LFTs that were present here. So this patient was already in SCI-B, probably cardiogenic shock at the time that they were diagnosed with a GI illness here. Unfortunately, actually received a fluid challenge and then was discharged. And so the recurrent presentation here 48 hours later should not actually be that surprising, but obviously concerning. Now is coming in extremis. If we go to the next slide, we see clearly that while the patient is not hypotensive, has now clearly become tachycardic and clearly has evidence of a severe heart failure with cold extremities and is in that worrisome cold and wet quadrant.
Yeah, and I just say here are elements that you may not be able to extract easily from your EHR, but really the clinical assessment of this patient, despite the normal blood pressure, really has you concerned about the possibility of emerging cardiogenic shock. All right, back to you. And I must say, it's always the young ones who are tachycardic that worry me the most because they hang on for a long time.
I should say that.
All right, go ahead, Kurt.
Great. Next slide, please. And so here's her EKG. We see sinus tachycardia, frequent PVCs, and some nonspecific ST segment and T-wave changes. And go to the next slide, please. And so her laboratory evaluation after this initial exam, we see new evidence of hyperperfusion. So lactate of 4.6, an NT-proBNP of 8,300. A high sensitivity troponin of 32 nanograms per milliliter. Our upper limit of normal here at the Brigham is 9. a creatinine of 1.2 milligrams per deciliter, and her AST and LT are quite elevated in the 1200s and 800s respectively, compared to the low 100s just 2 days prior. And next slide, please. And so an echo is obtained kind of upon arrival. Here we see, if you can play, please, hopefully this will come through. Great. We see LV dilation, poor systolic function. And then if you can click on the next slide, once this is run. And we really now see more biventricular dysfunction, certainly left greater than right, but her RV is not working well either. Next slide, please. And so she undergoes a pulmonary artery catheter placement. You can see the measurements here. Initially, an RA pressure of 26 millimeters of mercury, an RV of 58/27, pulmonary artery of 55/38 with a mean of 47 millimeters of mercury, with a PA saturation of 26%, and a pulmonary capillary wedge pressure of 35 millimeters of mercury. This occurred at the time of a heart rate still tachycardic at 126 beats per minute. And the systemic blood pressure, as you can see here, these values yield indirect thick cardiac output of 2.4 liters per minute and a cardiac index of 1.1, which leads us to an SVR of 2100 and a PVR of nearly 400, a pulmonary artery pressure index of 0.65, and an RA to wedge ratio of 0.74.
Kurt, I'm going to have you pause just there for a second, because we've had a number of questions in the chat about what prognostic indicators do people use, which are the most powerful, and relating to the hemodynamics. So Shashank, I'll ask you to comment. A question was, do we use the lactate? Is the lactate more prognostic than the invasive hemodynamics? And among the invasive hemodynamics, are there any particular ones that you hang your hat on with the PAPI, CPO, MAP, SVR? Sorry, if you could boil that down to a 20-second response.
I'll do my best. So great question. And the reality is all of them are actually important. It turns out more than lactate, the admission lactate, is the lactate clearance is important. And one of the questions I would have for Dr. Ginder is, was a lactate checked at the ED visit 2 days prior when the patient was treated and discharged? Because I suspect it was probably elevated, and then coming at 4.6. This is a great example where hemodynamics are actually very helpful. You can see that the RA is 26, so it was likely very difficult to see on your clinical exam because it was, as noted, well above the tragus, with a very reduced cardiac index. The markers that are actually extremely prognostic are the right-sided filling pressures, so the RA pressure, and then pulmonary artery pulsatility index. Those seem to be, at least across registries, across centers, to be the most prognostic. The cardiac power output was found to be useful based on the original shock trial published in 1999 and shown by Finke and colleagues in 2004. In subsequent registry-based analyses, we've not really seen that to be as prognostic as we initially thought. And so while helpful, actually these right-sided measures of dysfunction are actually very helpful because this patient is in very severe biventricular failure.
Yeah, as always, extremely insightful response, Shashank. And then I'll just add that through a question in the chat, yes, we absolutely have within our implementation in C3TN of the SCAI shock staging, recognize that patients with normotension and cardiogenic shock still fit at least at SCAI C. And if you do find the need for escalation, that they may even meet D, even if their starting blood pressure is normal. As you can see here, this patient's maintaining it simply because of the SVR of 2100. And as soon as you introduce any sedation, that's going to go away and they're going to become dramatically hypotensive. Mitch, if I can come back to you maybe in a few minutes just to keep to time, and then we'll let you comment at the end of the case. Kurt, go ahead.
Great, thank you very much. Next slide, please. So just to review kind of progression of SCAI shock stage over the course. Next slide, please. 2 days ago, potentially SCAI stage B, normal intensive cardiogenic shock with the blood pressure in a patient that was hypertensive previously, now much lower than normal, kind of that cutoff of 92/60, so just above the formal definition. A lactate was checked. It was normal at the time. Unclear to me actually if that was before the fluids or after the fluids or when that was checked, with a slight increase in AST and ALT. Now from the emergency department visit through hospital day 6, we have SCAI stage C cardiogenic shock with hypoperfusion by labs, by right heart cath. Her echo showed severe biventricular dysfunction. She was started on milrinone after this right heart catheterization was placed with a slight improvement or a modest improvement in cardiac index to 2.1. And speaking to her lactate trajectory, did normalize with this intervention. Her creatinine did slightly improve to 0.9. Unfortunately, on hospital day 7, she had clinical deterioration with hypotension, requiring a norepinephrine infusion, and so kind of progressed to SCAI stage D, cardiogenic shock, no longer with normotension, but now hypotension, and a decrease in her cardiac index and a commiserate increase in her lactate to 4.7. So I wanted to overview the kind of progression of her shock stage. During the day of that clinical deterioration, here are hemodynamics, just a deeper dive on that. She was placed on norepinephrine in between 3 to 5 micrograms per kilogram per minute, and the milrinone had been continued. Next, please. And the pulmonary artery catheter was still in place, and so we do see, her RV filling or RA filling pressure, RV function, and wedge are all mostly unchanged since the initiation of therapy 6 days ago. And her cardiac index is 1.7. The labs, as mentioned, a lactate of 4.7 and a creatinine now up to 1.4. And so next slide, please. And one more. And so she underwent emergent placement of a femoral balloon pump. Next slide, please. This fortunately stabilized her enough to get to a durable LVAD implantation with HeartMate 3. During this time, she did undergo LV core biopsy that was sent for pathology that didn't show any evidence of myocarditis or infiltration. It did show myocyte hypertrophy with vacuolization. And then she did remarkably well and was discharged to rehab about 2 weeks after LVAD implantation. Next slide, please. An outpatient follow-up genetic evaluation was unrevealing, and she's undergoing a transplant evaluation. And next slide, please. And so that's it. Thank you very much for the opportunity to present this case. Happy for any questions.
Fantastic, Kurt. I'll ask you one quick question, then have Mitch chime in, and then we'll move on. And Mitch, we are stealing a little bit from your HA summary time, if you can adjust when we get to it. But first, Kurt, why did the team pick a balloon pump instead of another form of MCS in this case? Yeah,
that's a good question, and I think maybe one of a time setting that we were placed in. I had to dig back to find a normotensive cardiogenic shock patient. This was a few years ago, and so I think if this patient presented again today, we may have more readily reached for a Impella. So I think it was more of a dealer's choice at the time, and so that was what was selected, but no clear rationale one way or another.
I'd say the other thing that we consider is outside the setting of AMI cardiogenic shock, where we now have clear data around using other forms of microaxial flow pump. This phenotype of particularly high SVR, maybe patients with severe MR as well, where unloading in particular afterload reduction may improve things. That might be a sweet spot for this balloon pump super responder phenotype, but we need data to sort that out for sure. Mitch, did you have a comment or a question?
Just a very brief comment back to the discussion about what are the prognostic indicators is just to remind everybody, as Shashank said many times, to think dynamically. So even with terrible, scary looking numbers in a snapshot, and while there are some that are clearly prognostic over a population, for an individual human being, keep in mind that where are you 30 minutes after you initiate therapy, and where are you at 24 hours? That sort of dynamic thinking also is really the prognostic trail as for this young lady as we work with this syndrome.
No, that's an excellent point, Mitch, and one Shashank had alluded to too, that dynamic risk assessment is key. I'm going to let you roll right with that comment into your section, Mitch, thanking Kurt again for a fantastic case.
Thank you.
Okay, thanks, David, Shashank, Kurt. What a great session. I'm going to go ahead to the next slide, please. Flash through this. Some of you who logged in for our first grand rounds have seen these. We want everybody to be familiar, though, with the engine the American Heart Association has provided with the shock registry to continue to drive this process as a learning health system oriented facility. The Cardiogenic Shock Registry mission is to create better understanding of the clinical manifestations of various shock phenotypes, management patterns, and outcomes in patients presenting with this complex disease, not just from clinical trials, but in real-world practice. Next slide. There are 5 core scientific aims: characterizing the epidemiology, producing an infrastructure for regulatory and clinical research infrastructure, driving evidence further that we can collect at high quality, creating pilot evidence-based performance metrics and pilot trials, and ultimately striving, as with all the Get With The Guidelines registries, to do everything we can to move the needle on health equity. Next slide. The steering committee of the Cardiogenic Shock Registry echoes that footprint of primary objectives with a variety of academic clinical specialties pulled together with industry experts, regulatory experts, and policy and payer experts, and along and really led by a phenomenal AHA staff, including Dr. Mariel Jessup, Christine Rutan, Jason Walchuk, who you'll hear from here in just a minute, Samantha Johnson, Shana Costello, who opened the session, and Maria Eisler. Next slide. I'll summarize this slide by saying, certainly in my experience, it's been amazing in the 2-year history of standing up this registry de novo. The team has beat every projected timeline, and we now stand with over 100 sites and more than 4,500 patients entered in the shock registry to date, and still growing. They're very upward moving trends. Real testimonial to the need, but also to the team putting this together. And last slide, I'll turn this over to Jason Walchuk to show you, as many of you are sites looking at or supporting the registry already, what you can do with your own data. Jason?
Thank you. It's a pleasure to be here with you guys. Just wanted to take a few minutes here just to kind of tie a few pieces together and kind of show how sites and how you that participate can leverage the registry and the data collection within the registry system and the platform that we have provided to you for reporting and analytics. So all registry participants have access to this reporting interface that exists. As your data is collected, you not only get access to your own personal data, but you can also benchmark against national data, regional, and also sites that have your similar characteristics. So in this demo, I just ran a quick little bundle of measures here, but I also added in the ability for us to filter and compare and stratify results by the different sky stages. And we have 2 specific discrete fields that capture the initial and then 1 for serial assessment. So I've added those in, and I've added some benchmarks. So just for an example here in our demo data, I'm showing a MCS complications report that shows a simple distribution of the 3 different benchmarks. My hospital's red, blue is all hospital, non-academic and Northeast CDC region. And so this is the overall MCS complications. I can now actually stratify that by utilizing some of those variables. So once you build your report, you can click in Sky Stage. We'll actually change this measure and this report into a categorical measure. And I'll filter down even further using the icon here on the right-hand side to take out my deceased and not documented. And I can break down those results. Changing measures will keep the filter in place, and I can actually switch over to in-hospital mortality to show the difference in in-hospital mortality, again, stratified by those different sky stages. These filters and the drill down on these individual variables, again, is available to all users within the registry. It works on both performance and our descriptive measures. So you could look at things like sky stage by race, ethnicity, sex. And one last final feature that is a nice add-on is that any of those filters that you apply to the system here in the parameter page show up in the measure detail in a case list so that you can then compare the initial Sky stage to the serial assessment one with all the other associated data elements that are used within the measure result itself. So wanted to show that and see if there's any questions, but I'll hand it back over to you, Dr. Morrow.
Well, that was tremendously efficient. Thank you, Jason. And really, I mean, a great illustration of how you can use the data that are at your fingertips. I must admit, every time I see Jason present, I realize how much more we could be even doing at my home institution, the Brigham, with these data. And developing the reports once and then saving them allows you to just generate them with a click when you go back in. So it's absolutely amazing what you all have created and made so facile for us at the site level. So let's go ahead and see if we have 4 minutes or so for some additional questions. I know that Dr. Chen had a question early on, and welcome you to come back in if you want to ask your question. I'll start. Maybe Mitch, this might be a good question for you. There have been several questions about non-invasive tools for risk stratification patients with cardiogenic shock, and maybe your view on that, since you've been immersed in this area for so long.
Yeah, I think we would all love to feel comfortable with these sorts of non-invasive tools for hemodynamics. If a sales rep comes into your place and puts it on themselves, they're always quite perfect. Unfortunately, where we'd like them to work perfectly is in extremes of physiology and mixed physiologies. And I think caution is a good word. The way we actually are using them here is to start at least with a PA catheter and calibrate the device to that PA catheter to at least gain confidence whether in a moment the two devices actually line up reasonably well. I will say in some more extreme settings, the absolute values on the non-invasive monitor are not identical to those of the invasive catheter. But where I think it's still useful is the trajectory. So wherever that match is, once you have calibrated the non-invasive monitor, whether things are getting better or getting worse is a legitimate trajectory to follow. So that's how we use them. If a patient is not in a good position to tolerate an indwelling PA catheter, to at least get a measurement, for instance, in a cath lab, and calibrate where you are with the non-invasive numbers relative to what I'd consider the gold standard. Then whether they're unloading volume or improving. The other thing that to me is very helpful with very abnormal hearts is as you move up or down in a filling pressure for either the RV or the LV, to be able to understand what is optimal, because in a lot of abnormal hearts, the Starling curve's sweet spot may be a number that in other settings we would consider pretty abnormal. So to understand for an individual where the Starling curve sweet spot really is for filling pressure is not so much of an absolute number, it's an individualized number. And following that trajectory, if you dry them out too much or if you overload too much, can be helpful. But I would not recommend for very sick patients using non-invasive plethysmographic and other types of technologies without a calibration step.
Yeah, and I'd say it's still a very important area for research. I think it's one of the areas that Elliot Miller and I identified as being valuable for the next 5 years for us to develop tools, because while we love our invasive tools for monitoring, we recognize that there are complication rates. The other thing that I realize is that certainly, as Shashank alluded to, we really can glean a lot more quantitative data from echo than we often do. And I always get chided by my European colleagues in cardiac ICUs about how much they use echo and non-invasive evaluation with echo. in this patient population more so maybe than we do. Anyway, well, that brings us to the close of the hour. I want to thank all of our presenters for an absolutely tremendous session. I definitely learned a lot. I hope that our audience did. The recording will be available to you as you want to go back and review some of this, and we certainly look forward to all of you in our next grand rounds in the next quarter. And please, as well, if you're not participating in the HA Cardiogenic Shock Registry and you're interested, please reach out to us. We'd love to hear from you and assess you as a site. So thank you very much. And with that, we'll close.